Hi, my name is Lakshmi Yatham. I'm a co-chair of the ACUMEN, an e-learning program on cognition for clinicians. The focus of today's module is on cognitive effects of psychotropic medications. In today's module, we're going to talk about, are there any negative effects of psychotropic medications on cognitive functioning in patients with psychiatric disorders? And if there are negative effects, what do we as clinicians can do to minimize those negative effects? And also we'll explore whether there is any evidence for efficacy of these psychotropic medications in improving cognitive functioning in patients with bipolar disorder or schizophrenia. To talk to us about all those issues, we have Dr. Joseph Goldberg, who is from the Icahn School of Medicine at Mount Sinai in New York. And of course, Dr. Goldberg is a world-renowned expert on this topic. Joe, it's so nice to have you here today.
Lakshmi, it's a pleasure. Thank you for having me.
Wonderful. So let's start with a very basic question, because in my own clinical practice, I look after patients with a bipolar disorder, and when they come in to see me, they often complain about cognitive issues. Could you tell us what might be some of the reasons for those cognitive complaints?
Sure. Well, so there are many, and I think mood disorder patients in general, but especially bipolar disorder patients, will self-identify cognitive complaints of one kind or another. Sometimes they will proactively tell you, I think I have ADD, or they will tell you, this medicine you're giving me is giving me ADD, or otherwise causing cognitive problems. And I think part of our job is to sort of suss out what exactly their complaint corresponds to. So sometimes there can be inherent cognitive deficits due to bipolar disorder. Some people think that that's part of the illness. It may even be part of what gets inherited. So much interest, as you know, in looking at family members of bipolar probands who may not have mood symptoms but have problems in the domains we know are affected in bipolar disorder, namely attentional processing, executive functioning, and verbal learning in particular, unlike schizophrenia where we see more broad effects. So that signature, those three things, tends to draw our attention. It may or may not be the case that someone has comorbid ADD if you go back in time before age 12 and you've gone through the systematic approach and family history. You might make a comorbid diagnosis, but it's really about 10% of adult bipolar patients who would have comorbid ADD, maybe about half of bipolar adult patients who have attentional processing problems. So one piece to this is to determine if what the patient is subjectively telling you is a cognitive problem is a cognitive problem. And this leads us to the differential diagnostic issues that come up. So sometimes patients correctly are self-aware and they identify a cognitive complaint. Some of the work that our group had done and others shows that the correspondence is not always perfect. Patients may self-identify cognitive problems but not manifest objective deficits. Or for that matter, patients may have objective cognitive deficits and not recognize cognitive problems. So what's the differential diagnosis? Affective symptoms, depression, anxiety, comorbidities, substance use disorders don't typically help cognitive functioning. The residual effects of episode burden over time, a multi-episode mood disorder patient may be more prone to have cognitive slips and cognitive deficits. So we're very interested in teasing out, when did this begin relative to pharmacology, relative to episode number, what exactly is the patient aware of? Are they euthymic or not euthymic? Are they recovering from psychosis or anxiety? And so on. And then we can come to the question of, is this iatrogenic? To what extent are medications that patients are taking potentially detrimental or possibly helpful, if not neutral, for cognition?
Okay, so you brought up lots of issues. So it sounds like there are many reasons as to why people with bipolar disorder may have cognitive issues. And you talked about the illness itself, the mood symptoms, other diagnoses that might co-occur with the bipolar, psychotropic medications, substance use. And you also talked about a bunch of things that we as clinicians need to do to try and tease those things out. The last point you talked about was the effects of medications, which is intriguing because, of course, we use these medications to treat mood symptoms. So how do we as clinicians then try and figure out, when someone comes to see us with those cognitive complaints, Are those related to medications, or could they be related to some of those other things that you talked about?
So here's where the detective work, I think, comes into play. Who, what, where, when, and why. When did you begin to notice these problems relative to changes in medicine? Someone who says, I've newly begun to have what I think is a side effect of a medicine I've been taking for 10 years is less likely to be iatrogenic than some other factor, someone who's newly or recently been symptomatic in some way. That may point us in a direction. So we want to sort of get a sense of timing and what regimen changes have occurred, try to change one variable at a time, and then try to be mindful of what medicine effects are more notorious for cognitive adverse effects and which ones may be more, as I say, neutral or more potentially beneficial. So let's start with the easiest, detrimental.
Yeah.
So highly antihistaminergic, anticholinergic drugs do not help cognition. If someone is taking something with a lot of H1 blockade effects, if someone is on a very anticholinergic drug, if they're obviously somnolent, they're talking with you and they're manifesting somnolence or drowsiness, or they just seem non-fluent in their thinking, that should prompt a clinician to look back and think, do I have you on a significant dose of an anticholinergic drug? Beta blockers that can be sedating. So we want to think about anticholinergics, antihistamines, dose effects, both of which can be dose related, and then the extent to which we can minimize exposure to those medicines. Second piece to this is then, is someone on a medicine that is known to be neutral, let's say. So most non-anticholinergic antidepressants and most anticonvulsants and most non-antihistaminergic second-generation antipsychotics at worst seem neutral when it comes to cognitive function. As you know, some may be beneficial, and we can talk about this. But the more antihistaminergic, anticholinergic, soporific ones, we would quickly begin to think of as problematic. If someone has extrapyramidal side effects and they're on benztropine and so forth, then we think about that.
Okay, so that's a sort of a general kind of an idea that clinicians might need to keep in mind as they think about using psychotropic medications. Maybe let's start with some specific medicines, because there are some medicines that we use much more commonly in treating people with bipolar than others. Why don't we start with something like lithium, which is, most of us consider as the foundation for managing bipolar. So is lithium beneficial, detrimental? What do you think?
Yeah, so this is an interesting question, right? Because from a preclinical standpoint, lithium is neurotrophic. Lithium should help nerve cells sustain viability in times of oxidative stress. They should prevent cell death. Lithium should prevent cell death. It should translate to a beneficial effect. Right. And indeed, there is some research, say in dementia, certain dementias at least, potentially diminishing the potential for progression of dementia. In the clinical world, the studies that have been done thus far don't speak to a clear-cut benefit of lithium when it comes to cognition. And clinician researchers like us would look back and say, well, why is that? I mean, lithium should help. It makes nerve cells grow. It sustains gray matter. Why don't you see benefits? So some would say, well, the reason studies have not particularly shown benefits with cognition in the case of lithium is fake news or inadequate studies, methodological problems, small sample sizes. And when you look at the literature, it actually is not so exhaustive. It's not the case that we've done, I think, the ultimate study of lithium monotherapy while controlling for all the confounding factors like the ones we mentioned earlier to be able to say is lithium beneficial or detrimental. I think that there is great interest in at least low-dose lithium in potentially having some value for cognition. I would not necessarily assume a detriment with lithium. And when people have articulated or identified deficits with lithium, they tend to be circumscribed around short-term memory, reaction time, and that can include things like finger tapping. So these are laboratory measures. I wouldn't automatically say reaction time when you're driving or associative fluency is necessarily affected by lithium, at least in therapeutic ranges. And nowadays we try to keep things on the lower than the higher side, especially during maintenance phases of the disorder.
Okay. So it sounds like from what you're saying, and based on what we know about lithium's pharmacology and its effects on brain cells and things like that, it should help It should improve cognition.
It should help. It should help to not hurt.
Right.
It should help if there is any kind of neuroprogression. At the very least, it should be beneficial in that respect. But as to whether the term will be nootropic or cognitive enhancing, that's, I think, still the mystery.
So it sounds like we don't actually have clear evidence to suggest that it is helpful, although it should theoretically help.
You could phrase it that way.
Okay. Now, you touched upon the potential negative effects of lithium as well. And again, just thinking about my own practice, I do see sometimes patients coming in on lithium complaining of cognitive dulling. You talked a little bit about it. So again, it sounds like there may be some evidence that it might affect some aspects of cognitive functioning, but the evidence is not clear. Is that fair? Or?
So, good point, because I think this again comes back to the subjective versus the objective assessment of patient complaints. Patients may very well identify themselves as feeling a little slower, a little less fluent, a little less rapid, a little less witty, and speedy. So here we have to be very mindful of what their mood state is. If someone has been in any way recently hypomanic, and keep in mind lithium tends to have a more pronounced effect on the high side than the low side of the illness, we want to identify that someone's not missing the highs. Or a patient once tell me, I hate feeling normal. I'd rather not be here than feel normal. They're not depressed, but they're accustomed to something a little bit above the baseline. So it's important, I think, to establish for any given patient what their sense of a normal baseline is. And that comes out in the interview as well. If I'm talking with someone and I'm clearly following them and they seem fluent and there's no stopping, cognitive flow and functioning, but they subjectively say, I don't feel as sharp. I might even ask, can you give me examples? And are you sure that it's not as sharp, or that you're just missing the highs, or that there's no depression in the picture? However, I do agree with you. I think patients will report some sense of not feeling quite as speedy and as perhaps fluent. Then we get into questions about, does lithium affect creativity, problem solving? And here's where I think the objective tests haven't been as helpful, because they're not extensive. They're laboratory based, things like digit symbol substitution, and from that to extrapolate as, say, someone is an artist or a writer or very verbally oriented, what is their subjective experience relative to objective? To me, the takeaway for that is try to keep lithium levels as low as are feasible, minimize concomitant medications that might disrupt cognitive functioning, assure that they're not mistaking cognitive complaints for low-grade affective or anxiety symptoms, and explore this over time.
Okay, that's pretty clear. Now, let's talk about anticonvulsants, because those are the other class of medications that we use commonly for treating bipolar patients. What do you think about the effects of those medications?
So class effects when it comes to anticonvulsants, we know are variable. There really aren't class effects. From a psychotropic standpoint, some, such as divalproex or carbamazepine, exert more of an antimanic effect than an antidepressant effect. A drug such as lamotrigine may be the opposite of that, and then some have no clear mood effects, but may have other effects. So let's break this down a few ways. When we extrapolate from studies in healthy controls or epilepsy patients or migraine patients to bipolar disorder patients, or for that matter, schizophrenia patients, we have to take into consideration what is the illness itself. A healthy control on an anticonvulsant may perform differently or experience cognitive perceptions differently than a clinical population, and across clinical populations there's variation. But as a rule of thumb, in usual therapeutic doses, carbamazepine, divalproex, and lamotrigine, let's say the three core mood-stabilizing anticonvulsants, have not been shown to have much negative impact when it comes to cognitive functioning. There's anecdote, there's lore. Lamotrigine, in the original manufacturer's studies, actually included some subjective measures of cognitive functioning and actually reported improvements in subjective cognitive functioning in the usual dosing range in the context of improving bipolar depression. On the other hand, that's dosing that goes up to 400 milligrams a day. If my patient is complaining of cognitive problems and they're on a higher dose, I might begin to wonder if that's an indicator of neurotoxicity or a drug interaction with something that might be raising up pharmacokinetics of lamotrigine. So those three drugs we tend not to think of as being terribly detrimental. Now we can also talk about the say the non-thymoleptic anticonvulsants or the psychotropic effects of anticonvulsants aside from mood. Drugs such as gabapentin, pregabalin, which seem to have anxiolytic properties, may help with sleep. Drugs such as topiramate, which can be very helpful in the world of bipolar disorder for the non-mood symptoms, such as impulsivity, substance use, migraine, binge eating, and so forth. Topiramate is probably the greatest offender when it comes to diffuse cognitive deficits. A third or so of patients taking topiramate will have what's probably dose-related adverse cognitive effects. Then there are drugs such as zonisamide, levetiracetam, which we don't use as much of in psychiatry, and so we have to extrapolate more from epilepsy. And epilepsy patients may have some baseline problems when it comes to cognition. So I think the takeaway is that the three core mood-stabilizing anticonvulsants in usual doses tend not to show much in the way of detriment, and some of the other agents, especially topiramate, we have to be more cautious.
Okay. Well, sometimes, as you know, we often combine anticonvulsants in clinical practice, right? Because you may have patients that are on valproate in conjunction with lamotrigine, for example, although there are pharmacokinetic interactions, but they have differential mood effects, and sometimes we do combine them. And there is a suggestion that sometimes when you have patients on more than one anticonvulsant, that combination might be more detrimental from a cognitive perspective. What are your thoughts on that?
I think it's certainly a possibility, both from the pharmacokinetic interaction standpoint, such as when you mentioned divalproex, valproate can increase lamotrigine levels. Carbamazepine can induce metabolism of other drugs. And if we have patients on multiple medications, it sometimes becomes a lot of guesswork to know what the pharmacodynamic effects are, both good and bad, especially when patients are on many medicines. There was a recent study from Institute of Living saying that 20% of bipolar patients take 4 or more psychotropic drugs, and there's a standard deviation to that. So it becomes hard to say, do you think drug number 7 is causing you to have memory problems? Here's where I think the clinician wants to be mindful of what's known. So if one is combining medicines at usual doses in a relatively euthymic patient without a history of head trauma and without anticholinergics and so on, and they're complaining of cognitive problems, it's possible that it could be iatrogenic, but that might be someone for whom neuropsychological testing would be helpful to tease out if the pattern that we see objectively is consistent with the subjective complaints. So I think additive effects can happen in combinations of anticonvulsants, but I'm especially concerned about the anticholinergics and the antihistamines, even more so than anticonvulsant combinations.
Okay. Now, the second generation antipsychotics, or the so-called atypical antipsychotics, is the sort of other group that we use very commonly for managing bipolar patients. What about the effects of those medicines?
So they're supposed to be better, right? I read that. I was taught that, and I've taught that myself. And yet we have studies such as the Katie study and other trials in schizophrenia, at least, where it's not so clear that the second-generation antipsychotics have a very clear signal of any advantage over first-generation antipsychotics, as in Katie, or even just from baseline within subjects in terms of trying to improve cognition. We've often thought in schizophrenia, it's rather obvious, improving cognition is a tremendous unmet need. I think the goal to improve cognition in bipolar disorder has more recently become a recognized unmet need. So of the studies that have looked at cognitive effects, for better or worse, with second-generation antipsychotics in bipolar disorder patients, the results are rather interesting. Let me talk about this sort of in two ways. One is from a mechanism standpoint, and then the other is from what we actually see. So second-generation antipsychotics, and I think we have a slide that speaks to this as well. Second-generation antipsychotics sort of invite us to consider different mechanisms above and beyond just D2 blockade, like a first-generation antipsychotic. We could think about partial agonists, such as cariprazine or aripiprazole or brexpiprazole, and the extent to which partial agonism at the D2 and D3 receptors may actually, at least in theory or in preclinical studies, benefit cognition, attentional processing. That is to elevate dopamine in prefrontal tracts where we'd like to see more so and spare the damage that can be caused by pure D2 antagonists. So there's some very initial preliminary work with a number of the second generation partial agonists that may have some value, more so in schizophrenia, I think, at the moment than in bipolar disorder. But that would be one component. Does partial agonism play a role? And if I'm sitting with a patient who is on a dopamine partial agonist, I may be particularly interested in, so by the way, you're showing up on time for things. Do you notice any effect on balancing your checkbook or getting your chores done? That's a sort of a bedside way of getting at that. So that's one piece. Another mechanistic piece has to do with different receptors than the dopamine system at all. So the 5-HT7 receptor, one of the serotonin receptors that we believe to be involved in diverse psychiatric manifestations, includes cognition, and there's at least preclinical data with 5-HT7 binding agents, antagonists, to improve cognition, and at least one study, I think by you, that spoke to the potential cognitive benefits of giving lurasidone, which is a 5-HT7 blocking drug, among its other properties, to relatively euthymic bipolar patients, and found I'm telling you your research, and found an overall cognitive benefit. That was one of the first studies that I know of that's actually spoken to a cognitive benefit, really with any agent. There's only a handful that have shown benefits. So the lurasidone data speak favorably. There are other 5-HT7 antagonists. Acenapine has some 5-HT7 antagonism. The novel antidepressant vortioxetine, which has not yet been studied in bipolar depression, does have some 5-HT7 antagonism. So from a receptor standpoint, I think we can ask, what's going on besides simple D2 blockade and trying to minimize antihistamine, anticholinergic effects that may have a pro-cognitive effect? So much to be determined yet.
So it sounds like from what you're saying, when second-generation antipsychotics became available, they sort of were touted as medicines that may improve cognition as a class. That hasn't really panned out. But there may be some specific second-generation antipsychotics that have a partial agonism at D2, D3 receptors, or 5-HT7 antagonistic properties might be beneficial, but the data is very preliminary at this stage.
Yes, I think very much so. It also lends itself to speculation about things like, if my patient tells me that they're thinking more clearly, is that because of a direct cognitive effect, or is that, as they say, pseudo-specific to, I've made their mood better, and so yes, now they can think clearly, and so on. So these are some of the fascinating questions that I think researchers ask, and clinicians should be asking them as well when they're interviewing patients.
Okay, so we talked about the potential positive effects of these second-generation antipsychotics. Do we know if they actually have any negative effects on cognition?
There's a class warning applied to all antipsychotics, both first and second generation, for cognitive impairment, and that largely comes from D2 blockade, carrying over from the first generation drugs. Pure D2 antagonists do not enhance cognition. They do not improve associative fluency. There's even, interest in the question of whether there may be some neurotoxicity with the first generation drugs, long-term in schizophrenia, in terms of cognitive functions. When it comes to the second generation drugs, and we bring in other mechanisms besides D2 blockade, especially if it's loose D2 binding, and so we're not pummeling the D2 receptor 24/7 the way some of the older drugs might, but in addition affecting 5-HT2A receptors, which have an inverse relationship with dopamine in the prefrontal cortex, and some of these other receptors like 5-HT7 that I mentioned. There may very well be some potential for benefit in that regard, but when it comes to detriments, aside from pure D2 blockade, antihistamine, anticholinergic effects tend to do things in. So if someone's very agitated, we may want to capitalize on an antihistaminergic, anticholinergic drug for its sedative properties, but at least over time, that's not going to be a very effective strategy if somebody then needs to get back to functioning and back to work.
Okay, so one needs to be really mindful about the potential negative cognitive effects of some of these medications based on some of those receptor profiles that you talked about.
Very much so.
Now,
and to listen to our patients when they tell us these things.
Great. Now, the other issue that comes up is the effects of psychostimulants, right? Because there's a perception that's out there that psychostimulants might improve performance. When it comes to patients with bipolar disorder, what do you think? Do they help? Do they make it worse? Or?
So I think psychostimulants are to psychiatrists what Rorschach projectives are to the rest of the world. We impose many ideas on stimulants as being all-powerful and either good or bad. Luckily, we now have some data that can go beyond just asking questions in our own minds about whether stimulants are good or bad. So in the world of bipolar disorder, and I think we have a slide on this, there have been at least a handful of studies thus far looking specifically at bipolar disorder patients with comorbid ADD or ADHD using psychostimulants, specifically lisdexamfetamine or methylphenidate, targeting ADD symptoms. And there's some older work in kids with bipolar disorder augmenting divalproex with mixed amphetamine salts. All of those studies, which added a stimulant onto a mood-stabilizing drug, have consistently found improvement in measures of attentional processing. Again, this is an ADD comorbidity in bipolar disorder, but it speaks to a signal. I don't know that the brain decides, I have ADD, and that is the distinct nature of my attention problem. I think in a more neuroscientific sense, attentional processing is a network. All right, it's a circuitry problem that we want to address. And much the way partial agonists of the D2, D3 system might get at that, so too might pure agonists, such as amphetamine or possibly methylphenidate. Obviously, the question is, do they help attention? Do they help executive function or other domains subserved by attention? And are they safe? Do they skyrocket people into highs? So the study that was done by Roger McIntyre's group with lisdexamfetamine showed a clear benefit in attentional processing, ADD symptoms, without any worsening of mania symptoms, which were low at baseline and remain so, and actually found benefits for depression symptoms. And there's some other data with lisdexamfetamine for bipolar depression as the primary outcome, showing benefit in depression symptoms when added to a mood-stabilizing drug without destabilization of mania. So these would be so-called off-label uses, not FDA approved, and they have to be undertaken with caution. And one would want to think, I don't want to give a pure D2, D3 agonist to someone with active psychosis or mania, or agitation, for that matter, but they may serve a very useful role when there's slowed attentional processing, when there are some elements of depression and no mixed features in the picture and no psychosis.
So they could improve cognitive functioning in bipolar patients with comorbid ADHD, and they might also improve depressive symptoms. I guess my question is, if you have someone with bipolar without comorbid ADHD, and if you use stimulants in that population, and of course I take the point that you're saying when you use stimulants, you got to make sure that they have other anti-manic mood stabilizing agents on board to prevent any risk of mood destabilization. So assuming that you add these psychostimulants to a mood stabilizer, in those situations, would they improve cognition or worsen cognition of bipolars that don't have ADHD?
To my knowledge, that is a very important study waiting to be done.
Okay.
But from my clinical perspective, I think that would be a very logical, pointed use of an agent, right? So again, absence of mixed features, you haven't just been manic a day ago and now you're depressed, but where there's psychomotor slowing, you think about bipolar depression, atypical features, lethargy, anergia, anhedonia, apathy, lethargy, psychomotor, slowing, that brings to mind the role of potential dopamine agonism, hence the interest in drugs such as bupropion, the novel Parkinson's drug pramipexole, that our group and others have done some studies on looking at bipolar depression, stands as one example of a psychotropic that may help attentional processing in bipolar patients. So I think a clinician is thinking along the right lines when they see sluggish, anergic, psychomotor slowing attentional processing. Might a pro-dopaminergic drug be helpful, provided that there's no current symptoms that are likely to worsen because of a dopamine agonist?
Okay. So two other class of medications. I mean, you already talked about the negative effects of anticholinergics, which we sometimes tend to use in patients with bipolar disorder to manage some of the adverse effects of antipsychotic medication. The other group of medicines that we use are benzodiazepines sometimes. What about those? Do they have any negative or positive effects?
Another very understudied area. So in STEP BD, I think we published some data showing that benzodiazepine use is extensive, and by extensive I mean beyond the customary 2 weeks that we often think of as being appropriate for benzodiazepine use in the short term to help with insomnia or to bring down mania symptoms. Clonazepam has data for that and so on. But longer term use, which may relate to insomnia, which may relate to comorbid anxiety features, can be common. So then comes the question, well, are they helpful for those things? Is a patient an appropriate candidate for a benzodiazepine? Do they risk becoming tolerant and dependent and misuse and so on? And then from a cognitive standpoint, are there any good things one can say about a benzodiazepine? And the answer is probably not, other than if someone is full-on fight or flight response, panicking, that will interfere with cognition. So bringing that down, short term at least with the benzodiazepine, may give enough time for prefrontal circuitry to come back online and think through a potential perceived threat. But long term, no, benzodiazepines have been associated with a wide range of adverse cognitive effects. And there's even questions about whether long-term benzodiazepine use may be a contributor to dementia in some patients. There have been a couple of studies, neither of which has been randomized controlled trials to establish causality, but at least some association between long-term benzodiazepine use and the potential for developing dementia. People with bipolar disorder inherently do have a higher risk for developing long-term cognitive problems, including dementia. So we have 2 risk factors now for dementia: long-term benzodiazepine use potentially, and then having many episodes in the world of bipolar disorder. Of course, the question is, does that mean that benzodiazepine exposure is directly contributing to the risk for dementia, or sort of confounding by indication, meaning someone who is beginning to show signs of minimal cognitive impairment may be more likely to get prescribed a benzodiazepine for nonspecific kinds of symptoms? And that's where I think the research has not yet directed us. So for the clinician, to me, that means if I am vigilant in monitoring adverse cognitive effects and I'm thinking through, well, what, if anything, should I eliminate or reduce to spare the burden of adverse cognitive effects? Does this person really need to be on 6 milligrams of clonazepam? And I at least want to have the discussion with them that this could actually be making your reaction time slower, it can make your processing speed poorer, and it won't do anything good to ward off the risk for dementia if that's a concern. So in that spirit, I try to at least remind myself and the patient that we need to revisit that question over time.
So it sounds like your message to clinicians is stay away from benzodiazepines when possible.
When feasible, when possible, try to minimize doses. I mean, certainly there is a subgroup of patients, in my opinion, for whom benzodiazepines, even long-term, may be appropriate, may be unrivaled. We'd like to have other medicines that would target anxiety or insomnia. We're not always successful. And so I think the decision to continue a benzodiazepine long-term needs to be very thought through on a case-by-case basis. And there are times where it's appropriate, but there are often times where it's not.
Okay, thank you. So that brings me to my last question, because we talked a lot about negative effects of various psychotropic medications and areas where there might be potential positive benefits. So just want to try and see if we can bring all this to the clinical realm, and that is when you have a patient, when a clinician has a patient with a bipolar disorder that's got these cognitive issues, and clinician has established what he or she is seeing in the patient is unlikely to be due to the medication that the patient is taking, and now thinking about, is there other medication that I could actually use to improve cognitive functioning? So do you have any recommendations for clinicians based on what we know, or would you say it's too early, we can't make any recommendations?
All of the above, right? So there is no established go-to treatment for cognitive benefit. There are certain treatments that might be more sparing. I like to point out for anticholinergic for extrapyramidal symptoms from tighter dopamine-binding drugs if dosage reductions are inadequate. Benztropine and trihexyphenidyl are not that beneficial, but drugs such as amantadine are sometimes more sparing cognitively and may have some value. It's a dopamine agonist drug, so that may accomplish the goal of addressing extrapyramidal symptoms while sparing the cognitive problems. If someone is a candidate for one of the drugs that's been shown, at least in preliminary studies, to help cognition, that would include, I mentioned pramipexole earlier, Kate Burdick's pilot study in bipolar disorder patients. I think the work that you very nicely demonstrated with lurasidone, potentially speaking to the role of 5-HT7, and that opens up more doorways to think about options. But lurasidone is an evidence-based option in bipolar disorder, in bipolar depression, and of particular interest when there are cognitive complaints. There's an interesting molecule known as Withania somnifera. I'm sure you're familiar with Indian ginseng. The root, the leaf, not sure which, but our colleague Roy Changappa published a very nice randomized double-blind trial using ashwagandha versus placebo to treat cognitive complaints in people with bipolar disorder. It is a relatively benign intervention, a relatively inexpensive intervention, and so that has, since his study came along, has moved higher up on my list of things to say to patients, you're having some cognitive problems. Let's consider things we could do to help that, and one of those things is ashwagandha. It is evidence-based. I tend to be a bit of a skeptic when it comes to anything over the counter or in the more alternative realm, unless there's an evidence-based trial, and in this case there are data with that compound.
You also had mentioned about the D3 partial agonists as well, such as cariprazine.
Yes.
So it sounds like there are no data as yet at this point in time to think about agents such as that.
Well, I think we're in a time of greatly rapid moving. What's the way to say this? I'm having cognitive problems. We're at a time of great evolution in the field and a lot of rapid advancements. So cariprazine has its FDA indication in bipolar mania. There are 2 completed and either published or soon to be published randomized controlled trials for cariprazine for bipolar depression. There are some cognitive measures that have been included in those data. So I think the new year will give us an opportunity for more information on that very intriguing possibility.
Thanks very much, Joe. Very helpful summary of the cognitive effects of psychotropic medications. Maybe let's finish off by asking you to give us 3 clinical takeaways from this module for our clinicians.
Sure. So I think first and foremost, clinicians need to be aware that cognitive symptoms can be part of bipolar disorder. They don't necessarily need to invoke additional diagnoses. They may be iatrogenic related to medications, but they can be part of the illness. So that's one piece. And evaluate it. Psychiatrists don't always get in and do the right kind of evaluation. And if someone's having complaints, spend a few minutes doing a MOCA. It doesn't take very long, and that'll give you a lot of information about whether there's value to be had in doing more formal neuropsychological testing or not. So recognize that it's there, recognize that there are many possible causes, and then go through those causes. So reviewing a roster of medicines for the kinds of adverse consequences of things, antihistaminergics, anticholinergics that we mentioned, benzodiazepines, redundancies, medicines that may not necessarily be helpful or necessary, substance use, alcohol, all the things that we think of or should be thinking of that could be contributors, so that we can finally get to the question of, all right, am I treating something iatrogenic or am I treating something that's part of the illness? And then once we've honed that down, I think as a final point, in either case, are there medications, and not just medications, I mean, the things like cognitive remediation merit attention as well, but are there interventions that I can apply that may be helpful in targeting these symptoms once I've optimally treated mood, optimally treated anxiety or other comorbidities, tried to eliminate substance misuse and so on, and then I know what I'm clearly looking at. And when in doubt, formal neuropsychological testing can sometimes really help shed light on what the target of treatment needs to be.
Wonderful. Thank you very much.
Thank you, Lakshmi. Real pleasure.